right, so welcome. I just want to make sure that, okay, everyone feel free to go get food and drink at any point during this. Don't feel like you have to, wait on ceremony. We're going to get started. Just so that people know, there is a live stream also happening that will be, I believe, available on the Baruch website, as well as a YouTube channel, as well as we'll have a link to it from the PCDC YouTube channel as well. So I think we're going to get started. So welcome. I'm Louise Cohen. I'm the CEO of the Primary Care Development Corporation, which is a community development financial institution, a community loan fund that has been around in New York City since 1993. We on-lend capital to primary care and behavioral health organizations to expand their physical plant, their services. We provide technical assistance and training to improve access and quality and lower cost. And we have a policy team that has put on this event today. So I want to first thank the team who has put this together. I want to thank Anna Popenchak and Jordan Goldberg, Jonathan Yan, Anthony Gomez, a whole host of other people who really worked hard to put this event together. I want to thank all of our panelists as well, and you'll get to know more about them in a minute. But first, we had a sponsor for this event, the Marsh McLennan Agency, so I just want Patrick Zerpa, who is a commercial insurance advisor, to come up and just say a few welcoming words.
Hello, everyone. Thank you, Louise. Patrick Zerpa. I'm an advisor out of Marsh McLennan, the sponsor for this event. Super excited to be here. My partner in crime, Harry and Shane, who works on the employee benefit side, could not be here today. And he has 102 fever right now, but he's tuning into the live stream, so he's here in spirit. And anyway, I'm sure most of you are familiar with Marsh McLennan. We're an insurance brokerage firm, largest in the world by revenue. I'm part of the healthcare team here in New York City. We partner with organizations like PCDC to assist and provide educational resources for the space, both community health and on a hospital system side. So definitely super psyched to be here and learn something. I myself work on the property and casualty, as mentioned. So if you need any help with that or are looking for support from a broker partner, happy to connect with all of you after the program. But appreciate the time and looking forward to learning something today.
So we're always grateful to our sponsors for supporting the work that we do. PCDC is proud to provide an annual opportunity for our primary care community in New York and around the country to get together and talk about what is happening in the field and how we can together improve access, quality, and equity in primary care. This year, we have to acknowledge that there may well be some very big changes coming in the next 4 years, some of which we can anticipate and foresee, and many things that at this time we cannot. We may see some changes in how Medicaid and Medicare are structured, how access to insurance, public and private, may change. There could be changes to the Affordable Care Act. There will be certainly different leadership at federal agencies. There will be issues connected to funding for women's reproductive health. There will be issues around access for people who are undocumented and for things like gender-affirming care, which we in New York State have supported and promoted. Some of these changes may increase inequities, they may drive down access, and may disrupt longstanding policies for the safety net services that we know are essential for the communities that we serve. Things like work requirements, or something that's been floated, which is the need to recertify for Medicaid 3 times a year, which we know will drive down access and ability to utilize services. But there are other things, like how Medicare sets its reimbursement rates by taking rate setting out of the hands of the American Medical Association, might be positive for primary care. We have also heard from John Thune's staff, he's the incoming Senate Majority Leader, that federally qualified health center funding is a must pass. And that gives us hope. So we need to watch all these things closely and be ready to take action. So it's in this context that we turn to our issue today, which is how do we use healthcare and cost and economic data to drive policies that strengthen primary care in all ways? So what gets measured gets done. You all have heard that a million times. You've probably said it a million times. The antecedent to that is what data is actually available to measure. And the sequela is we will draw conclusions from that limited data set that we have available to us. So there's a lot of healthcare data around. Some of that data is longitudinal, perhaps not very clean, often expensive to collect, and maybe proprietary. Some collected data is around episodes of care, some is utilization, some is public health data. Dozens, if not hundreds of organizations around the country in some form or fashion collect data, build data warehouses. They could be accountable care organizations, private equity-backed data shops, state institutions, consulting organizations, academic medical centers, academic programs for health policy and the like. And if you believe, as PCDC does, that the evidence over many years supports that primary care is fundamental and drives better outcomes on both the individual and the community level, then we also have to acknowledge that data to continue to understand primary care is fairly sorely lacking in New York State, in particular, to prove the case today, building on the work that has been done over 20 years. So today we're going to wrestle with these issues. We've got some experts and some thought leaders, and I believe that this will be a really useful conversation and hopefully just the beginning of the conversation that we can have with all of you who are in the room today and those of you who are watching. So I'm going to turn the podium over to Jordan Goldberg, who's a Senior Director at PCDC, for the first panel. And again, please, at any time, get up, get some food or some drink over here. The bathrooms are outside. There's other housekeeping. Those are sort of my housekeeping things I neglected to mention before I left the podium.
Feel free to find a place that's good. And I'm just going to say for tech, I'm mic'd already. Can people hear me? No, people cannot hear me. A little bit better? Is that better? Okay. I'm not in control of this, but there's someone somewhere who's like modulating this as I'm talking. So thank you wherever you went. Thank you, everybody, for being here. I'm Jordan Goldberg. As Louise said, I'm the Director of Policy at the Primary Care Development Corporation, and I'm thrilled to be moderating this panel of experts that we have here today to talk about the value of health data in informing policy and ultimately in expanding access and improving quality of primary care. Our panelists are three amazing experts from New York State. I'm just going to back up a little bit so I can see them and see you. We're joined by David Horrocks, who is the CEO of the New York Health eHealth Collaborative. Dr. Oxiris Barbot, who's the President and CEO of the United Hospital Fund, and Ann Schettine, who's the Director of the Office of Health Services Quality and Analytics at the New York State Department of Health. And I did practice that title because it's very long. They are all extremely experienced in this area, and I encourage you to review their bios, which I'm not going to go through because it would take the whole panel, but you can get them through your QR code that's on the pamphlet on your table, and for those who are online, you can get it on the website. So I wanted to save that time for our conversation. Oh, and I can advance our slide. Our goal for the panel today is to get a better understanding of the landscape of health data in New York State and how that data is informing policy and practice. One of the things we're going to talk about is why the data systems look the way they do right now and some of the challenges and opportunities that are posed by that set of facts, as well as the fact that we've got several new systems and programs launching in New York State that implicate health data, like the 1115 waiver that's been starting over the last year, and the new CMS Ahead model that's going to be launching in the next year. So I'm going to moderate just by asking each of our panelists some specific questions, but I encourage you all to respond to what someone has said, ask another question of our panelists. We have so much expertise on the panel, we don't want to miss out on that, so we don't have to be super formal about that. So I'm going to jump in, and I'm going to start with David. To set the stage for our conversation, I'd love for you to tell us a little bit about the types of data that exist, health data that exist, and what they're used for. And you have given us this really great, I'm just going to have to, slide that sort of gives us a Venn diagram of all these different things.
It's one of my favorite slides, but I wish I had made the font larger, you know? Oy. Well, yeah, thank you. If you sort of start at the practice level and what data is being generated, obviously there are medical records that we think of as being generated to help clinicians understand and manage care. You have billing information, which is generated, obviously, follow the money. You also have quality information that's generated through some practices. We call these QRDA files. And then some reportable conditions, maybe, that come out of practices that go for public health purposes. Well, these data get aggregated for lots of different uses. When they're put together, they get used for coordination of care in other locations. And really, HIEs, such as the CHIA, were generally formed with that purpose in mind, getting clinical information to the next doctor or nurse so they understand what has happened, their ability to diagnose and treat is improved. But they're also used by public health officials as part of surveillance. They're used by policymakers to understand things like network adequacy or prevalence of disease. Increasingly, we have social factors that get married to this clinical data. A little bit of it that is now is generated at the practices themselves through screenings, and then you've got financial policy as well. And the diagram shows that there are organizations that get formed to use this aggregated data, and they have overlapping purposes. You've got HIEs who need more real-time data, and it tends to be more clinical. You've got CDC, and those public health data modernization also need data in a more real time. And then you've got policy-making functions maybe down the bottom that aren't perhaps real time. They maybe are more claims-focused than they are on clinical data. So lots of different types of data, and they get aggregated by probably a bunch of organizations for somewhat different but overlapping purposes.
Thank you. That's an extensive and useful explanation for all of the context for the discussion that we're about to have. And I think particularly when we talk about timeliness and time sensitivity, we're going to get to that in a little while. But it's very important, I think, when it comes to collection of data and how we access it. So that leads us to you, Anne. I'm sorry, I can hear it. It's getting in and out. So tell me if you can't hear me. Just someone raise. Okay. So your job involves overseeing much of the health data that's collected in New York State, much of what David was just talking about. So I wanted to ask you to talk about a couple things. How you make decisions about what data you decide stays within internal to the state that does not need to be made public, or you choose not to make it public for the reasons that I'd like you to talk about a little bit. Also, when you've decided to make something public, how do you decide what format that goes in? Are you going to make a dashboard or a graphic, or create some portal that allows people to take a little bit of a deeper dive?
Okay, first I'd like just to level set, like the things that I'm responsible for, what my office oversees, is a lot of it's a little bit more retrospective. So the all-payer claims database for the state, we also collect some information from the hospital systems, usually called Sparks data, but it's like the inpatient, outpatient ED data from Article 28 facilities in New York. So those things can tend to be retrospective, and I think when you were first speaking about like what does the state need, so there is other data that's being pulled in, particularly for public health surveillance at this point, but that needs it for that emergency planning response types of work, or things that they might need for communicable disease. But there are a lot of the data that we work with is generally a little bit more retrospective. It also comes in because it's processed usually through a billing system or a transaction. It'll have other information that's kind of gets put on it. So some of the cost data gets added to it. There'll be other things that might be put on that would allow us to additional structure to the data so that you're able to use it a little bit easier when the data comes in. The things that we use as far as the criteria of what data do we keep or do we not, usually the first thing you start with is what is the purpose of the data? So is there the laws or regulations that are around that data? There is some data that's for particular purposes, which they'll say that is protected and it's never going to be released. But largely for the data sources that I'm responsible for, the things that we'll look at are, is the data fit for use? So meaning, is it complete enough? Does it have the type of information? Can it answer the question you're asking? Is this the right source, or is there another source that's better for it? And once we have what we're asking of the data, then we make the decisions about, how do you prioritize which things to start with? So oftentimes it goes back to, what are people asking for? What kind of questions are coming in? How often is that being asked? We have about 250 data sets on health data in New York right now. We look at how many of them are being used, and are people connecting to them via an interface, so they're pulling them regularly, or is it something that they just come in to see? But once you get into how you've had the data prepared into that kind of data set or a data cube, oftentimes what we'll try to do is say, what's the intention of that particular data set? If we're talking about utilization, how might somebody want to use that? Then you might create some type of Tableau or other type of report tables, whatever it might be. You might want to tell a story about that. So we're really trying to get to not just the data and making the data more readily available, but also how do you tell that story to people so that they can interact with it and understand it better. So there had been some efforts at the department during the pandemic to try to get some of those kind of storyboards are. Like might there be a particular outbreak, or where might we have things happening? So again, that people are expecting, I'm gonna know that piece of information, rather than I may be a researcher and want the data sets, or I may just be somebody that's interested in something. So really trying to meet people where they have their need for information.
That's really helpful, and it leads right into my question to you, Dr. Barbot, which is, once Anne and others in the state have decided to release that information, what can you tell us a little bit about how UHF uses that?
Sure. So we use the publicly facing data in a number of different ways, but let me start off by saying that Anne and her shop, I think, really do an exemplary job on making data publicly available, more so than many other states. Maybe not at the top, but certainly more than other states. And specifically, we use the QAR data, quality assurance reporting requirements, a really important way that we are able to track differences between health plans and what the outcomes are. We can look at implementing continuous quality improvement projects, as well as differences between Medicaid and commercial plans. And so that's really important for us. The other way that we use the publicly available data, it includes the hospital discharge data, the provider network data, the Medicaid enrollment data, and all of these sources allow us to better understand what's actually happening on the ground. And as you were talking, it really struck me that what we want to do is we want to be able to draw on data that we can rely on so that we can tell a particular story. And interestingly, you, from the perspective of government, want to make those data pieces as useful as possible, so that when we in the non-state arena are making these stories, we're not making up fiction, right? Like and so putting that, really simplistically, I think is important for us to think about, because these data don't just magically appear, right? They need to be cleaned, they need to be digested, they need to be put into context. And so the other way in which we use the publicly available data is by, we have a insurance dashboard on our website, and most recently, as an example, we took the publicly facing data that was available through the Medicaid Unwind to help tell the story of how New York was able to be a leader in terms of making sure that people didn't fall off of their Medicaid coverage because of let's say, administrative issues or being pushed off like in other states. And so that was important for us. And then we also are able to access the data that's available through non-public channels, through the contract that we have. And through then our analyses, make those findings available. So for example, the latest was understanding Medicaid utilization for children in New York State, which is another way in which we can take non-publicly available data, but then analyze it and make it publicly available for use in program development, policy analysis, et cetera. So we use that data that's available in a number of different ways.
I feel like there's a number of things to follow up on there, but one of the things that came up when we were talking about this in preparation, and that has already come up on the panel, is the timeliness of data and how when data gets released really impacts how you can use it. So I was wondering if you could tell us a little bit about the way that the data becomes available to you, can impact how it can be used for a range of things, service delivery, research, and to inform policymaking.
Yeah, no, absolutely. And when I was thinking about this, I come at it from someone who has delivered care and was interested in using data to analyze how that care made a difference at the individual patient level. Also as someone who's been in government and looking at collecting data and making that data useful, and then now someone on the nonprofit health policy side. So that I bring all those parts to this sort of response. And I think about data in three different ways, right? There's real-time data, there's timely data, and then there's ideal data, right? The real-time data, and David, you sort of alluded to this, was data that's collected that is useful at the point of care, right? If I'm seeing someone in the emergency room, I want to know what their labs were when they went to see their PCP 3 weeks ago, vice versa. Those are the things that matter at the individual level. The other thing is, we need real-time data to respond to emergencies, right? Like certainly, when we were leading efforts for COVID in the first phase, there was a lot of data that we wish we had in real time that in retrospect, there were systems that could have been put in place and that are now being put in place so that we have data that's going to be useful in emergency response more readily available. The second category that I think about is timely data. And this data to me is not data that necessarily has all of the depth that we would want, let's say for research purposes, but is data that we can use to monitor inflection points, right? And so the example that comes to mind is in responding to the opioid overdose epidemic and looking at the number of people that die because of this. At the city level, we were looking at quarterly data that was able to tell us, are the numbers going up or are the numbers going down? We could make policy decisions based on that, but we didn't necessarily have all of the depth that could have been used, let's say, for more in-depth research. And then that brings me to the third category, which is data that may not necessarily be as timely, but is more robust. And Anne, I think you were talking about this earlier, data that can help inform research and policy making for the long term. The challenge here is that oftentimes this is data that can be complex to collect, complex to clean, and complex to display. And so that then, by definition, makes it less timely, right? But when you're thinking about using this data for policy making, I think that's okay, and you would want that. The last thing I'll say on this is that sometimes we think we want real-time data or we want timely data, and then when we get it, we're like, this is not helpful, right? So for the example I give for that is, again, at the city level, and I can say this because I'm no longer in government, but I'm not giving away any secrets, it's like, we were collecting hemoglobin A1C data in real time. And then year after year, we tried to look at it and make sense of it, and it was just like, this is not really helpful. This is not any more helpful than the data that we can get from EHRs through, our HIE partners. So I think it comes back to something that Anne said in terms of being very clear with what the question is that you're looking to answer to be able to make decisions about whether real-time, timely, or more robust data is really what's needed.
That tees up my next question to Anne perfectly. That's extremely helpful context. And I was wondering if you could reflect a little bit on what Dr. Barbot was talking about and thinking about how you make decisions about the timeliness or the timeline on which you're releasing the data that you do release and how this informs your thinking about setting your own policy.
And I like that frame quite a bit because I think that said it in a more succinct way than I think some people are, when they're asking me for it, don't really think about. But and I would agree. I mean, I think there is times when you need information at the moment, whether it's for care or if it's responding to something, or there are those kinds of times when you need that. I think when we work with the data sets we have, oftentimes it's looking at trends over time. I like the point about an inflection point, though. So a lot of the data sets that we're creating, we think of it through more of an annual, like the data is complete. So I would say, like, for almost anything that I do a regular release for, it's probably lagged between 9 and 12 months, depending on what the data set is, for all the data from the previous year to be complete so that you can say it. And I think the other side of that is that the users of this data are not necessarily set up to run their analyses over and over again. Like if I were releasing provisional data on a more frequent cadence, it would make things have to be repeated. So again, I think depending on who the user is, whether they want to answer a question once, or if this is something that they're going to continue to refresh. So we do have a lot of things that we talked about annually. We've had some discussion about putting provisional data out, like with more of a quarterly, but then having to take it down to replace it. So we'd have to work with the users of it to see whether or not there's really an appetite for, we release it more often, but you're gonna have to be replacing that with more refreshed data. So those are some of the things I think that you wanna be thinking about. In particular, I think we do have a lot of people using our data more for research purposes, but there is a lot of policy making, and I think that's usually thought about more of like, what's the trend over time, often done by year, sometimes by quarter, but what data sets would be able to do that.
Mm-hmm. And I also really love the the categorization that you came up with and the levels and how sometimes the kind of data you're getting is not the right kind of data for what you're trying to do. What you just said, Anne, brings me nicely to my next question, which is, and this is, I would say, something that PCDC is specifically focused on, so I want to make sure I emphasize it. We believe that primary care does not receive enough investment, and that is part of the reason that there's inadequate supply and not inadequate access. In order to really understand what's leading to that, we would want to understand the spending and claims data, which we know lags and is one of these things that's either timely or ideal as opposed to something that you need in real time. But can you talk a little bit about the challenges of using spending data to inform the kinds of policies we're interested in decision making? And perhaps, if it's relevant, the state's involvement in this new CMS Ahead model and how that's going to maybe impact your analysis of spending data.
Mm-hmm. Sure. So, we've been working on primary care spending within the all-payer claims database for the past year or so. And we've created specifications and a definition of primary care spending. So it requires we bring together things about the type of service, the type of provider, and the setting that service has been delivered. And we are going to release the information about primary care spending in the first half of 2025. So we've made that commitment. We're making progress to it. But I think trying to think through what is that story of what is a primary care investment. A couple of the things, again, I think we're probably thinking more of like an ability to trend over time as we have more attention on primary care and what primary care leads to, how it contributes to the overall cost and quality for individuals. So, we will do those pieces of it. I think some of the challenges we have with all payer claims database, and this is not unique to New York's, is it has some information. It may not have everything that's being spent. So depending on what somebody's trying to answer with that question, it may or may not be there. We currently do not, and we talk about it, but it's not going to be coming in the near future, of the non-visit-based payments. So if we have more and more of these alternative payment arrangements or value-based care, that can create a missing piece of what might be going on there. So trying to acclimate to what we've seen in the past and to what we see going forward. I think, one of the challenges, quite honestly, is that we do get, we do purchase Medicare fee-for-service data. It's probably one of the most lag sources we get. So I think we're working through with Medicare as a state, participating in ahead on how they're going to try to make information more readily available to the state, at least for the participants that are going to be involved in that model, to be able to help inform. I think, we do things like we'll be able to use all payer data as well as, other sources that the Medicaid program will bring to be able to plan for that. But, I think our thinking is we're going to have to probably use other things like changes in utilization by sectors to say as a proxy to when we're going to see those costs, because it's not going to be necessarily as timely. But how do you put some things around it so that you can get acclimated to what do we think this is going to be if we don't have it? So I think we're still thinking through what are those challenges and how are we going to address them, but those are some of the early thoughts.
That's really interesting and really helpful to see some of the, into the window of what you're thinking about when these new models and new policies come in. And on that note, David, I wanted to turn to you to talk a little bit about the other model, that's the other policy that's happening in New York State, the waiver. So both of these models and programs, I don't know what we call the waiver, are focused on health equity. And that is sort of the driving motivation to getting all this data and understanding what's happening in the state so that we can advance health equity and improve access. I think everybody in this room is probably aware that with the new 1115 waiver, there's a heightened focus on data integration and interoperability, and that the state has really important goals around that. Can you talk a little bit about what your work is in that process?
Sure. So the CHIA is supporting the department as they work to create interoperability in support of the waiver. And the part of the waiver, the 1115 waiver I'm referring to, is that part where we want to employ community-based organizations to to address unmet social needs. And probably most of you are familiar with the structure of the waiver. It requires us to do a lot of screenings. We'd like every beneficiary to be screened to identify unmet social needs. We want those screenings to happen in many different places, including potentially in practices. And those have to make their way a few different places. They have to get to the regional organizations, the social care networks that are responsible for coordinating the activities. I think there are 13 regions. They need to get back to the MCOs where an individual is a member. They have to make their way back to OHIP and into the Medicaid data warehouse so that the OHIP team can run the reports necessary to show CMS our progress under the waiver. And they also need to get to the next clinician, right? The person who has a patient in front of her and wants to understand whether she's been screened, whether she's had a referral for services, whether those services were being rendered or not. All of that requires interoperability. And so we are bringing to bear the 6 regional HIEs. We call them the qualified entities, or QEs for short, and they will work with the practices and those social care networks to make sure that the screenings move, that the other direction, we can get copies of the referrals and screenings to the clinicians. We'll send copies of these to the Medicaid data warehouse and then to the HERO so that the HERO can do the evaluation of opportunities and whether we have an equitable rollout of the services and all of the other things that we want to do with this new social factor data that will have been collected. So the Schettine is really about the interoperability and giving hopefully clean data sets to others so that they can do the analysis necessary to advance the cause.
So if everything goes as planned, as you've set this forward.
If everything goes as planned, that's right.
Famous
We've
last
got 3
words.
weeks
I just
before.
want to
Yeah.
qualify that a little bit.
Yeah.
What do you think the potential is for all of this data to help the state effectively improve access to care and advance health equity? How do you think this will play out?
Well, we've never had great social factor data, or some would say social determinants of health data, that can be combined with other health outcome data. And I think that's a great opportunity, not just within the confines of the waiver activities and the work that these community-based organizations will do, but also to better understand chronic disease. And even if you think to the beginning of the pandemic, well, is there a disparate impact of this infectious disease? It was very hard to evaluate that in the early. We're looking at other countries and to get their read on this. Well, I think with more social factor data, we should be better at doing those things.
That's great. I realized as I was reviewing my questions that this may have been in the wrong order, but I think it's actually helpful. I would love for you, Dr. Barbot, to talk a little bit about your perspective on how data is currently being used to advance access to quality primary care and improve access and also advance health equity.
Yeah, so there are a lot of different ways in which data is currently being used, but I want to sort of reframe the way that we're thinking about this to say having more data isn't always the right answer. It's like, what do you do with the data that you have, right? And so I think for me, the way that I think about it is, do we have the mindset of when we're asking analytic questions to ask it from an equity perspective on whatever the data set is that we're looking at? And if not, I think that's a missed opportunity that we can, as a community, leverage. The second thing is having data that is as complete as humanly possible when it comes to demographic factors that can be proxies for underlying drivers of inequality, right? So talking specifically about having New York be a leader in the completeness of our race and ethnicity data on clinical data, which is not where I think it could and should be. So that's, I think, an opportunity for us to think about how can we use technology and how can we use linking certain data sets to help us improve that completeness. And that's actually one of the things that David and I have been talking about in terms of sparking that conversation and having people generate ideas. The third thing is, when we think about generating analyses for health equity, it's not limiting ourselves to race and ethnicity, but looking at geographic disparities and certainly looking at income inequality as a driver of inequities and outcomes. And I think doing more of that in our state is something that would be helpful for helping us advance health equity for all New Yorkers, right? Not independent of, but including race and ethnicity, geographic distribution, as well as income inequality. And then the fourth thing that I think about in terms of the data that we have and advancing health equity is I do think having a more robust provider database that helps us better understand who's providing care where, especially primary care, and in what dosage, right? Are they there once a week or are they there 5 days a week? Can help us make, I think, more informed analyses on, are we spending the money in the right places, and is the money that we're spending being clustered in certain areas, or can we be doing better at having a more equitable distribution of primary care services and getting the outcomes that we think that we should be getting for the money that we're spending.
Those are really good points, and I know that the data folks and research folks at PCDC would be very eager to see a lot of the stuff that you just talked about. Particularly regional data is so important in New York State because when it's aggregated, it's really hard to see some of those big holes that we have, and some places where we have really sufficient access and the quality of care is pretty good. So we have, for our last question, I'm going to ask each of you to talk a little bit about where you hope to see New York's health data and access and utilization in the future. In a year, in 5 years, maybe give us both perspectives. What would you like to see change, and what do you hope we keep doing correct?
Well, 2 years ago, the governor said she wants us to be nation leading in our ability to gather health data, do health surveillance. So I think that's a good goal. I think that's certainly what I get up trying to help achieve every day. I'll mention a couple things that I would like to see us address over the next year or two. One is, well, really they're related, patient privacy and use of data, and our ability to share data, or really to combine data that's been collected in other parts of state government, in different parts of state government. We don't combine the data well that's already collected, and often it is some policy decision or attorney interpretation, or there's concerns appropriately about patient privacy that we're not handling well. So we should fix that. At the same time, I think the mechanisms we use to protect patient privacy and to give patients real choices about how their information is used, they are weak. They are not, they're very well thought through, but in practice, they are ineffective. How many of you have gone to the doctor and had to sign one of those little signature pads, and you're staring at the back of a monitor? And that is not a meaningful anything. That is, but that's what we're doing. We have to get better at really protecting patient privacy and make it work in a way that we can combine data to do things that are in the best interest of patients.
That was great. I really appreciate all that insight, and I'm glad that this is being recorded because I wanted to write it all down. And do you want to share your insights?
Well, I would agree that our ability to integrate data is something that needs to happen. And I think, building on what you're saying about patient privacy is, how do we combine that data while protecting it as best we can? So really trying to lean into more of a master patient index to be able to say, you can have keys in various data sets. How do we link those without necessarily saying, this is Ann in this data, and this data, and this data? So I think there's things that we're trying to work towards to be able to do that. In the near term, I think my focus has been, we've reached a real exciting point with our all-payer claims database. So in this next year, it's really about pushing a series of public use files out. And then, re-engaging with the stakeholder community. We had a lot of good meetings with stakeholders on a regular basis about what things they were looking for. We want to get that going again now that we have some things situated to be able to do those things. So I think those are the kinds of things we focus on as far as what do we want to see for access for the data in the coming years.
Well, that's very exciting, too. And I'm sure there's folks from my organization who are delighted to hear that the stakeholder engagement is going to pick back up.
Yeah.
And Dr. Barbot.
Wow, it's tough batting cleanup here.
Sorry.
So I would say in year one, the completeness of our race and ethnicity data is just off the charts, and we're able to do good stuff with it. And then building on what David and Ann have said is linking data, but having an ecosystem where that's not the end point, right? The end point is having a community of users that use that linked data to hold government accountable for resource allocation and for improving the outcomes of our communities. Because oftentimes, it feels like we have conversations that kind of end with the technology and don't take that next important step, right? It's not just to like, it's a cool thing, we could do it, we've proved we've done it, and then move on. It's like, okay, now what are you gonna do with it? And how are you gonna use that to improve people's lives? So in 5 years, I want us to be there.
That is a wonderful note to end on. I appreciate that so much. I think we've heard a lot of really important insights. We're going to turn it over to Q&A now, so don't leave. There are 2 mics set up in the room, and anyone who has a question for any of the panelists, just come on up to the microphone. Yeah, I'm going to turn a little bit too so I can see better. And if not, yeah, feel free to come up. And if you have a question, can you just say your name? If you're affiliated with an organization you'd like to share that, go ahead. But there we go. Great.
So this question is for David. So you talked about the qualified entity and all of those pieces in between, and then interoperability and Schettine. So can you just reiterate, because you gave us a lot of information, so how is this going to happen? I mean, how many, right? It's not just a straight line. So if you can just give us a little bit more information on how this is going to happen.
Sure. Well, let me focus on just the screenings that will be part of the waiver work. Those screenings might be done by the social care network or their affiliates using software that the SCN has purchased. And now the SCN has a copy of that screening. If that is where the screening happens, they will send a copy via their QE partner up to the Schettine data lake, all right, where we're going to have a single repository statewide of all the screenings. That same screening might happen at a primary care practice. And then that primary care practice will use their QE partner to send it up to the data lake. So now we have everything from the primary care practices in the data lake. We'll run nightly batches, in all likelihood nightly, that go back down to the SCN so they get the screenings that they didn't otherwise have, and that push out to the Medicaid data warehouse so they have copies of all the screenings. And then we'll push, probably as limited data sets, the screenings maybe once a week, once a month, over to the HERO so that they'll have a copy of those screenings. Meanwhile, the QEs each have, if you're familiar with their ability to deliver clinical information back out to the emergency room or to a primary care practice, they'll use those same vehicles to be able to say, here's a screening that your patient had 3 months ago. And they'll do that by hitting against that statewide repository in real time. So I know that's a lot to picture without a diagram, but that's how we'll move the screenings. And we've been practicing every one of those steps for the last 5 months. So it works with lots and lots of test data. And we were talking, once the ball drops, it's going to be live data. So we're getting close.
Thank you, David. Does anyone have any other questions? If not, then I will say thank you very much to our panel. I really appreciate all of you coming here and sharing your insights with us.
So bear with us while we change panels. Again, there's food and drink over here. There's also a lot of seats over here for those of you who might be standing and want to come sit over here.
we could get seated to begin our second panel, that would be fantastic. Thank you. Okay, wonderful. Well, welcome back, everyone. My name is Anna Poppenshock, and I am the Director of Research and Evaluation at PCDC, and I'm thrilled to be here today to moderate our second panel. We've already had a really wonderful conversation about the state of healthcare data here in New York, and I'm thrilled to be able to take the opportunity now to take a step back and be able to discuss the national context. Our panelists today are Kevin McAvey, Managing Director at Manatt Health, Erin Bonney, Director of Health Informatics and Reporting at the Center for Health and Information and Analysis, CHIA, in Massachusetts, and Dr. Susan Bean, Vice President and Executive Medical Director at Health First. All three of our panelists have really extensive biographies that I encourage you to read using the QR code on your program on your table. So our goal for this panel is to really share a vision of what is possible with healthcare data and infrastructure by discussing examples that currently exist in other states. All three of our panelists have extensive experience working with and in other states, in health systems, and with different types of data. And we're going to hear from them today about what is the benefit of having a really extensive health informatics and data system. What can New York learn from other states? What are best practices and barriers around healthcare data? And why increasing access to these data are essential. Without further ado, Kevin, we'll start with you, but again, we'll moderate this panel similarly to the way that the first panel was moderated, where I'll have specific questions for the panelists, but I really encourage all three of you to comment, ask additional questions so that we can have a really in-depth conversation. So Kevin, you have worked with health data experts all over the country, and you yourself are an expert in using health data to drive policy and systems change and build accountability. To begin today, can you share with us a vision of what is really possible and some of the best practices that you've seen and the most effective uses of health utilization and care data, and why these data are important?
Yeah, can you hear me okay? Okay, that's a really good question. And to answer it, I would actually kind of put the question back to everyone here and those looking online and those working in our policy environment to set what New York's vision should be for its health data ecosystem. There are many forms and shapes it can take, and I really call and urge a sense of impatience in actually seeking to set a vision and work to realize it. I think to do that, we have to really think about why we need this type of data, like what we're going to use it for, how we can collect it in the most efficient methods, and how we can actually kind of develop infrastructure to sustain its collection, to derive information that's meaningful and useful from it. And so I've worked with states across the country to help them think through what their visions are, and I have the privilege of working with Ann and David now to help us a little bit think about what New York's vision would look like. But a couple of key components and ingredients that I've seen for states successfully realizing the potential of health data include having that vision in mind and broad stakeholder buy-in for that vision, having leadership in place. And I'm very thankful that we have a governor calling for a nation-leading health system, a commissioner calling for a data strategy, Ann and David for really setting forward and being dedicated to realizing what we can accomplish in New York. And I think David has already demonstrated us through, and Ann through the last conversation, what a little bit of impatience can do. As we start to really transform the value the CHIA can deliver for us as participants and at the state level. And then I think we need broad stakeholder buy-in. And so I was asked to talk a little bit about the art of the possible, and we'll talk about it more through this conversation. But I will note a couple of examples. I'm on the board of the Center for Improving Value in Healthcare in Colorado. They get out, and I'm so glad that we're getting our APCD data out next year, and it's really exciting. They get out limited data sets from their APCD, I think on the tune of 50 a year. to public stakeholders for broader use. And I would love to see that as part of our vision and something we can accomplish here. Arkansas really brings data sets together and links them really effectively to derive new types of information to answer questions one data source and data set alone isn't capable of answering. And Erin in Massachusetts, CHIA, an organization near and dear to my heart, has really and historically set the pace for how to, in an independent state agency, bring in data sources together and pair them to create context about our health system and create a sense of purpose and accountability. And so I think as we talk about the art of the possible, we have to look beyond what we have done traditionally in New York to really look at the pace setters to inform how we're setting a vision. And I would ask Dr. Gleed, I know I'm looking forward to the next conversation, if we don't have a chapter about like opportunities for system modernization, I think it's a real lost opportunity, especially as we think about where we can accomplish big things within that are high priority for our state, as well as with the new federal administration. What better place than really thinking about system transparency and efficiency? But again, I think Massachusetts brings a lot to the table and examples that they can set.
Thank you so much. That's a wonderful place to start with and leads perfectly into my next question for you, Erin. As Kevin said, Massachusetts has been a real leader, and I know our team love all the work that CHIA puts out. Your dashboards are beautiful. And you oversee analyzing and reporting on primary care and behavioral health spending, as well as total health expenditures. Could you share how Massachusetts and CHIA have worked to make these data more public-facing?
Yeah, absolutely. So for a little bit of background for folks that might not be familiar with the Center for Health Information Analysis, or CHIA as we're more commonly known, state government, so you need an acronym. So we were created in the fall of 2012 as part of Massachusetts' broader efforts to contain healthcare costs. And part of our mission at CHIA is to serve as a steward of Massachusetts health information and promote a more transparent and equitable healthcare system, and so helping people and organizations make informed decisions. And so as part of our work, and as part of my team's work and our agency's work, in terms of making our data more public-facing, I think one thing that we have really made a lot of progress in over the 10 years that I've been there and our 10 years of creation is tailoring our products and our reports and our data with our audience and our stakeholders in mind. So frequently, our reports are chart packs that are very graphic and visual, and I hope do a really good job of pulling out high-level, state-level findings. So if you, are interested in primary care and you just want a snapshot of what's the big picture here, you can pull the static dashboard, print it as a PDF, and you have, here's this overview on access to primary care services in Massachusetts. If you tend to be a more data-centric person, you really want to get into the details. I know that we've asked your team this of well, what data source did you use? How did you link this? We also have more detailed data sets in Excel. You can go pull it into whatever program you want, or interactive tableaus that have additional data cuts, additional stratifications for those more data-centric users that do want to dig into it. And so creating report packages that have elements at each of these levels that really provide something for our audience and our readers and people that are using this and stakeholders and market participants, so that whatever your experience working with data is, whatever level you need it at, you can see and highlight and get those key findings that CHIA is highlighting from what we're seeing, what story the data is telling.
And I think what you said there really complements nicely what the earlier panel was talking about how so much of what data we use really depends on what the user is asking of the data, and how do we set it up so that it is answering the question that the user is interested in. And we really, as I said, your work is so great, and I think it really is a testament too of how, yes, we have a real range of users, the data-centric people, but then also having those graphically, visually appealing, accessible tools are also so important, especially when we're thinking of policy change and trying to get the data into the hands of stakeholders who maybe not feel as confident in data. Kevin, reflecting on what Erin just said, what do you think New York can learn from Massachusetts' example?
I think New York can learn from the experience of many states, including Massachusetts. I mean, Massachusetts set up a highly efficient, stable, independent, financially secure, independent government organization that can take this data and report on how the healthcare system is doing. Is that something we want? I think we need a set, or what we want, over the course of the next year, over the course of the next few years, and be really impatient about it. Do we want to set up? I think we are really taking significant steps to developing a clinical information exchange ecosystem that not only provides data at value back to participants, but ultimately back to the state, really deriving meaningful, I think we were talking about real-time or near real-time information to support and make sure that we are prepared for the next pandemic, because it's going to happen. I mean, how does that relate to what we want in New York State? How does it relate to actually breaking down historical silos within New York State Department of Health and our departments in our state, to get new information out about the health needs of our populations and make sure that they're getting connected to services? I mean, when we think about addressing whole person care, the spirit of the waiver, I mean, those I think are essential, and those are foundational to actually get us anywhere we want to go.
That's fantastic. My last question for you is also just, you and Manatt came out with that great framework for healthcare data organizations. And I was just curious, from your experience working with all of these other states, do you see that there's a benefit in promoting alignment between states, or do you think states are doing such different things in different ways that that's not really the end goal?
Yeah, and I'd love to hear Dr. Bean's thoughts on this. But I think that it's alignment can be helpful for benchmarking once we have things to benchmark against. But I think alignment can also give you real acceleration power coming out the gate to get something started quickly. Just to call out an anecdote, like in Georgia and Texas, they established their APCDs. I think legislation passed 3 years ago, 4 years ago, where they're starting to get some reports out of it, which is really great. I mean, Massachusetts, it took us a little while to figure out what we were doing because we were among the first. But there is that real kind of convergence theory when you do learn from other states and how they do it, what lessons learned they have. It can really allow us to accelerate the work that we're doing here.
Wonderful. Susan, now turning to you, you're really an expert in health system transformation, and from your experience, could you tell us what are the benefits and challenges of using health insurance data to define population and health outcomes?
Well, thank you for that question, and I appreciate my colleagues very, very much. Our claims are the building blocks for all the things that we're talking about, and so all of the opportunities that we experience on a local level in our health plans roll up into all the opportunities that you're talking about. What I am finding, and I want to sort of turn this conversation a little bit to, since we are with the Primary Care Development Corporation, I want to turn a little bit toward primary care, because at the end of the day, the outcomes that we need are going to happen with practices on the ground, with beneficiaries, with members, with our social care networks, et cetera. And so all of the data movement, integration, and frameworks have to inform what's happening day to day with real people, real New Yorkers. I do spend a lot of time talking to my colleagues around the country about what they're doing. I think their approach to things really informs, because we're all looking at the same evidence-based medicine, and we're all wanting longevity with quality. And so what I would say is that our health claims data does help point us in the right direction. Remember, it's rich data. It's not just medical claims, it's mental health and behavioral health, it's pharmacy, it's dental. Soon it will also include some social data, et cetera. That's all going to be great. And to translate that to primary care, we're going to have to think about how we move that three-dimensional data into an office that's often two-dimensional. And I do feel like the health plans have really turned in that direction because of value-based care, because we do have to have our practices as allies to help move the needle on some of these bigger outcomes that we're looking for. I do also want to call out the state and Schettine and her teams have been working with us forever, I think we said earlier, in terms of giving us a concept for how that can happen. And so the work that we've done in New York State to actually align primary care practices with some of the bigger picture in terms of the data sets that you're creating, et cetera, using them to actually advance what the questions that our primary care practices are asking is really helpful. But I feel that we can't leave out primary care in terms of delivering and answering questions, delivering data and answering questions that are really meaningful to these practices, and then rolling up to health systems, health data organizations, and so on.
Excellent. And could you share more about, how these data can answer the question about what we are spending on primary care, or even also what you were just talking about? What are the questions that primary care practices are asking? What would they want to be using this data for?
Well, primary care practices want to transform. They don't want to be bound to the old model of primary care where it's a doctor sitting in an office with a few people around them, and they're limited to their, sort of four, walls. I do think that primary care is thinking big about how they can bring the value. In fact, only they can bring the value, because we're talking about the primary care practice as a hub. And so as a hub, there should be data coming and going. And from the health plan point of view, what we try to do is take two-dimensional historic retrospective data and make it a little bit more three-dimensional, so that the practice can have aha moments about the populations that they're serving. And I think there's much more that we can do, especially with the relationships with the SCNs and some of the things you talked about, David. But I feel that primary care is transforming, it's evolving. And the data questions that my colleagues are going to be asking are going to change as well.
That's great. Coming back to you, Erin, CHIA has done such important work in advancing primary care in their own state, and I'd love to hear how you have leveraged the healthcare data that CHIA has to advance primary care with some specific examples.
Sure. So I will talk about one of our newer data collections over the past couple years. So in Massachusetts, primary care as well as behavioral health have been policy priorities. Our previous administration and our current administration, there have been proposals to set targets for increased investment in these two areas, recognizing that the importance that they play in services. And so as part of that, particularly when you're thinking about what is our goal, what is our target, it's really difficult to conceptualize that if you don't know how much you're spending currently. You can't say, increase how many steps you're taking by 10% if you don't know how many steps you're walking in a day. And so in 2019, our former governor put out a proposal, and in response, CHIA began a new data collection to specifically measure how much we are spending on primary care and behavioral health services, and where those dollars are going. So are they being spent in office visits, on evaluation and management services? Are they being spent on vaccines? What does it look like for commercial members versus commercially managed Medicaid members? And so we issued data specs. We defined primary care towards the end of 2019 for the initial data collection to be at the end of 2020, because we thought that would be great timing at the end of 2019. Nothing else would be going on in 2020. So got that first data collection in. And now a couple years into this aggregate data collection, we've really been able to leverage that in a couple ways. So one is on a specific report detailing how much we're spending on primary care and behavioral health services. And again, being able, even within the past couple years, we've been able to separate out within behavioral health spending for mental health services versus SED, being able to look at spending for pediatric members versus adults, because their needs and their spending are very different, as well as particularly most recently looking at the integration of those two. So we're talking about primary care, and working with other organizations, primary care providers are providing behavioral health care. And so how can we capture that unique overlap in that unique section of the Venn diagram and quantify, here's how much is being spent in terms of behavioral health services that are being provided in a primary care setting. So we have an annual report that gets published every year on that. The data comes in. It falls into that timely category of that brilliant framework, which I'm absolutely borrowing from here on out. So year over year, it's a really good annual benchmark. We also, for our primary care dashboard that we worked with Massachusetts Health Quality Partners on, that spending data informs the finance domain. So here's how much was spent. Here's what that breakdown of. It's not just primary care. Is it going up? Are we spending less? What does that look like as a percentage of our overall spending? And also has been able to be used to inform legislative and policy proposals, because we really do now have a couple years of data that we can say, here's how much was spent in this year, and here's what that looks like as a percentage, or here's of these, certain number of service categories. These are the numbers, these are the data that can really help inform either how things are framed, or even just giving people and participants in these really great and really robust talks the same set of facts to be starting from.
If I could respond
Yes,
to
please.
Erin for a second. So I am so excited to hear you talk about primary care plus behavioral health. And I would say that when we get to access to care, what we're going to find is that we sort of have our traditional view, okay, patient walk into your primary care office, and that's what we're looking for. But what I'm seeing more and more is that primary care is, any place that you can find my attributed member or patient, I'm happy about. And often, especially during the pandemic, the place where that happened was in the behavioral health setting. And so I think we're going to see the value of primary care extend, so that the value of primary care is really around how people experience longer life, healthier years, et cetera. For example, in mental health care or mental health diseases or conditions, we know that the loss of life and the loss of years that drive costs come on the physical health side. So we do need to sort of, I feel, think a little bit differently about the questions we ask, and that goes to what you said, Kevin, about being intentional, about saying at the end of this time frame, what we want to see is a patient will link to primary care through other providers, or some other questions that can be of interest.
And I also don't want just, I couldn't agree more. I also don't want plans just to have that information. I want all of us to have that information. I want all of us to see how much is being invested in primary care and what outcomes does that lead to. And I think we're starting to build elements of that infrastructure and have infrastructure that can support answers to so many of our questions. I would love for to be part of New York State vision and what we accomplish in the next 5 years.
I do want to also say that what our data historically has not shown us is what people, consumers, patients are feeling about their healthcare. I think we're going in the right direction with screening for social needs, et cetera, especially since it's going to be widespread screening. There's no prerequisite that you're already accessing care. But I do think that to accomplish some of what we're talking about here, we have to be able to hear the voice of the patient. And I find that practices are finding ways, whether it's natural language processing or other ways to incorporate the voice of their patients, their clients, advisories, et cetera, to sort of understand why people are not accessing. So I do think that we're going to have to consider the why of some of what we're seeing. Access to care is really a reflection of how the system functions for people. And if the system is not functioning for people and they're not accessing, we don't have their claims data. And so that is something that we really do have to consider.
Do you have anything? Otherwise, that's a perfect segue into my next question. But I think what you said is so true, because Well, one, I think we always have to remember the stories behind the numbers that we're looking at. And too often, I think when we're looking at aggregated data, we forget about the people who are going into the practices or who might not be able to access care because they couldn't afford to get the bus that day or something. And switching gears a little bit to data availability, I think what you brought up is a really big limitation of some of our data sets where we're not capturing the people who can't access our healthcare system. And what do we do about that? What are the research methods or other data sources that we can use to address these data gaps? And how do we account for this limitation while we're trying to really address health equity when we know that we're missing that portion, this important portion of the population? And would love to hear any of your thoughts. That's a question to all.
I do have thoughts. So I feel that, you know, some of our provider groups in various configurations, federally qualified health centers are a great example of this, are reaching into the community to find people and to take away sort of the stigma of not being a quote unquote care accessor. And I do think that there is an opportunity to bring back trust in the system. But again, I go back to that voice. The voice starts in the community and then, you know, sort of leads into where we're actually seeing data, which is through claims and screening, et cetera.
Yeah, I'll hop in quickly just as one thing that, as our role of reporting on a variety of healthcare statistics and being an independent state agency, we have the ability to go out and collect data to fulfill that responsibility. And so when we're thinking about, you know, the limitations of aggregate data versus the limitations of claims data, it's kind of all of these trade-offs. And so looking for additional sources is vital, and looking to additional states that are doing the work and additional organizations is also invaluable. CHIA has survey data that the Massachusetts Health Insurance Survey is issued every other year. And so we have found, particularly with our team's work on the primary care dashboard, has been really valuable looking at the consumers themselves. And so we have this every other year. We have these snapshots saying 40% of residents said that they were unable to access care when they needed it in the prior 12 months. And so it's for a variety of reasons of my doctor didn't have an appointment as soon as I needed it, or I couldn't find childcare to cover my time away, XYZ, but also seeing that, you know, 80-something% reported that they have a usual source of care. And so as we do this and learn a little bit more, we're able to add in additional questions of, that's great, you have a usual source of care. What is it? Is it a doctor's office? Is it an urgent care center? Which, again, helps inform and at least increase, put some numbers behind and allows people to either take something away or identify places that they might want to target. This is great that we have such a high number of people that feel that they have a primary care physician, that feel that they have a usual source of care. Let's focus in on this 3-4% that their usual source of care is an urgent care center. What can we do at a statewide level, or what can organizations do at a statewide level or at a community level to help, you know, either increase, decrease, like whatever the solution is, and then ideally we'll see that on the data in the back end.
And that's what I think was really cool about the CHIA, and also in California, HCHIA, the Department of Health Access.
Affordability.
Thank you. Previously, OSHPD, forever. Is having access to all of these different data assets and resources in one place to really start to tell, and I think someone said it before, like tell a story of the patient, really get down to a geographic level to start to be responsive to care needs you see in the community. When you don't have access to a primary care provider, your populations aren't showing up in claims. Or showing up in claims with chronic conditions. I mean, I think you can then start to direct policy action to ultimately improve the health of populations in a way that individual plans might not have access to that data for that patient, who may move from plan to plan over time, who may switch from provider to provider over time. And I think it's that high level perspective that I think the state can play a unique role in a health data ecosystem.
Erin, I'm really curious about this survey because I think it adds a lot of nuance to some of the data that currently exists. Could you share a little bit about, I mean, just thinking of the logistics, I'm just sure there must be a lot of challenges and barriers that you face while implementing it, and I'd love to just hear more about what that has been like in terms of implementation, in terms of barriers, but then also any opportunities that you found as well.
Sure. So the team that runs that survey, which is not my specific team, does a really good job and works very, very hard. So I want to make sure that I'm happy to put anyone in touch with the correct people that can speak to all those really great questions. But broadly, yes, the team spends a lot of time getting the instrument developed, getting it deployed, but it is really valuable to have these snapshots every other year, going back for the past couple years where we can see these trends. There's always, I think, with any team that's doing survey work, you have the basics of response rates. I think from a data team, an analytics person that does not have to work on fielding the survey, I can come up with 100 additional questions. Can we ask this and also this, but then a follow-up, can you break this down and can we get this breakdown? And at some point, if you are fielding a survey, if you're responding of like, we can't ask them 250 questions. We have to narrow it down. And so what are the priorities and what can we use for proxies and kind of what are the availabilities, but what are we really trying to get at? And also allowing and making sure we do have consistency so that we can trend that of here's the snapshot from 2021, here's that same question in the percent that said they have a primary care provider or had difficulty accessing services or had to delay care due to inability, due to financial concerns or financial strain. We want to make sure that there is consistency that we can benchmark that. So I will I will hype it and say it's really robust and it's really great. And yes, the team works very hard, and it's, I'm sure, similar to challenges with any other survey.
Excellent.
But it does provide really great qualitative resources.
Excellent. Well, we wanted to ask a similar question to you all that we asked of the first panel, which is, where do you hope to see New York's health data and access and utilization data in the next year or in the next 5 years? But also, given your experiences working in or with other states, if you'd like to reflect more broadly nationally or in Massachusetts, we welcome your thoughts as we think towards this idea of a vision for the future.
Go first?
If you're welcome.
I don't know, man.
Do you want me to buy you some time?
No, there's no time, and that's the problem. I don't know whether I'm the only one feeling this, that we're running out of time, and I don't know that sounds like ominous, and it also might be because like I'm waiting any minute for like we're gonna have a third baby, and like I'm definitely running out of time. I think that folks. I've lived on Long Island and upstate New York and Auburn and Ithaca, and now I'm in Westchester, and I accumulate friends along the way, and they're all impatient. They see the more and more dollars coming out of their paycheck, and they're not seeing anything come back from it in the insurance that they're getting. They're not able to access primary care. They're not able to access services that they need. And I just feel like this increasing sense that either we're going to disrupt the way things are working right now, or things are going to be disrupted for us. And I think a nation-leading health data system, setting a foundation, setting the pipes, and showing what's possible to support our healthcare environment, healthcare delivery, demonstrating value back to the people who are paying for our system is a wonderful goal that I would love to be part of in any small way.
Yeah, I'll weigh in on the impatience part.
Impatient, call for impatience.
I find that primary care is impatient.
Mm-hmm.
They see so much that they could accomplish based on evidence, based on examples of of successes that we have even had in New York State, but it never moves forward. In other words, the system sort of constrains to more of the, I'm going to call it traditional ways that we've thought about healthcare. And I think for me, I would really like to see less I feel like's going on and more of the evidence shows going on. I mean, I think that that could really...
Do we snap now? Is that
okay, thank you. Yeah, I really feel that that could enable us to ask better questions and accept what the evidence says. If the evidence says this, that is true. We can't make it say something that it doesn't say. And I think that's a challenge, but I think there's an impatience. I'm an internist myself, and I think there's an impatience for primary care. My colleagues in nutrition here, all of my colleagues, I see you out there, my primary care colleagues. There's an impatience to really finally implement what works for people to have long life with quality.
Excellently said. Erin, anything that you want to add?
I mean, as someone that
I want
spent
to move to New York.
well, as someone that spent the first 21 years of their life in New York and now lives in Massachusetts, I would say we are thrilled to have more and more states join us in measuring healthcare spending and measuring primary care. It's incredibly helpful and really invaluable, even at the most basic of benchmarking of what are we spending compared to our neighbor states, but also more colleagues to discuss and brainstorm and how can we capture data that appropriately captures the nuance for these really important things to allow us to trend things in a timely manner but still being robust that can inform and say this is what the data says. So we're always thrilled to have more states and more friends join us in this work. So I would be your cheerleader from the sidelines, the neighboring state over. So very excited to see what New York has in store over the next couple of years. It sounds like there's a lot of really great work going on, and thrilled to see what comes out of many of the organizations here.
Thank you. And thank you to all three of you. This has been such a wonderful conversation, and I have taken copious notes. But I really like what you said about the call for impatience and also just articulating the real people behind these numbers and the data that we are trying to move, why we are trying to move this forward and why we want to use data. Data is such a powerful tool, but we really have to know what are the questions that we're asking for it and how we can use it. Because like you said, sometimes we really do want robust data, but we might not have the time to wait for that because we need action and we need to be using more timely data to be able to really work efficiently and effectively. So with that, I would love to open it up to questions to our panelists to be able to continue this conversation with all of you in the room. There are the 2 mics available for anybody who would like to come up and ask a question. Please introduce yourself and what brings you here, or where you're coming from.
Hello, Patrick Mascio. I work for 1199 Benefit and Pension Fund. And one thing I didn't hear too much was like the commodification of data, right? So there's people who like sell data, there's people who analyze or sell their analysis of the data, and then there's people who sell their acting on that data. And when you have a market, immediately kind of the focus becomes the profit. So I'm just wondering if there's an example of a program, a data source, a state, government, international, that does like all 3 of those things, focused on the health, and does it well.
Focused on the health. Can you elaborate on that a little bit?
So like if something's commodified, the focus is on selling it.
Yeah.
So, is there an example of a system, again, maybe it's a program, a state government, that is focused on actually achieving the health instead of like segmenting and looking at efficiency and, selling the product?
I'm happy to start.
Yeah, go for it.
Okay, so I don't want to get in trouble. So we guys, we have tremendous health information inequities in our country right now. There is plenty of health data out there for sale. Your health data, our health data. If you have enough money, you can buy information about our healthcare system in order to support your decision making. For research purposes in our team, we have to pay X dollars to get access to information to answer our questions. And you know what X dollars is? Well, what is it for? can you tell me a little bit more about your client who's going to be using this data and how much they could potentially pay for this data? Public data, like understanding how our healthcare markets work, I mean, it's an imperative to help us understand where folks are suffering and how we can address it. And I think that more and more states are starting to realize the public role in rebalancing these health inequities. And I think Massachusetts, again, comes back to, again, with the establishment of the CHIA, the data agency, and the Health Policy Commission, which takes that data and information and actually uses it to protect and insulate this organization. And there are a number of other examples across the country of states seeking to address some of those information inequities you alluded to. I don't know if you have anything else.
No, I don't really have anything else to add.
I think I would answer your question, Patrick, a little bit differently. I think that part of our answer to that
Commodification.
Thank you. Could be a lot of what New York City does, which is to tell the community what their health is. You know, I do think that we have to involve our consumers more in that work, and I do feel and see that communities actually respond to the fact that, you know, this is my health need, and maybe they can become part of a conversation around how data is used and for what purpose.
Yeah, and talk about leadership. I mean, like not only do we have, and I saw this in just California over the past couple of years. We had a governor that was data focused, we had a secretary of Health and Human Services, and we had an undersecretary and a CDO, like all kind of aligned. The stars aligned there, and they expanded, they set a new rule for health information exchange to also include social information exchange within that framework. They invested in HCHIA to expand its workforce to include a 100-person Office of Healthcare Affordability. And I'm not going to comment on that. But I mean, like, I do think that that actually state investments in actually breaking down barriers, investing in new capacity is important. We have the leadership at the state right now with the governor, the commissioner, and like really helping lead us. And also at the city with DOHMH, and I think the new center that Mom does is establishing to help us understand like the health of our populations neighborhood by neighborhood.
Thank you. Any other questions? The mics are waiting for you.
Very tall. Hi, I'm Remley Newton-Dame, New York City Health and Hospitals, the big public safety net hospital system for New York City. Excuse me. And I'd love to sort of bring us even deeper into the murky waters of equity. I think one of the things that we haven't exactly talked about, but there's this tsunami of data and AI coming towards us, right? We can see the tidal wave. Health systems are all individually trying to figure out what they're going to do as a million people pitch them. Public health is like scrambling for crumbs at the table. We then simultaneously know, right, from ample literature that bias is hiding in all the nooks and crannies of our data. So being able to cut all of our data by our key sociodemographics is a floor, not a ceiling, right? But we know that Black patients don't spend enough compared to how sick they are. And so if you are predicting cost and using that to apportion resources, you are going to be biasing your predictions against Black patients, and they are not going to get the same care access that other more affluent patients are. And I would love for us as an institution, as a set of thinkers, to not get together in another 10 years and write all the same papers about how AI perpetuated bias and how our healthcare infrastructure and systems that we're building did exactly what they were designed to do. So this is a gotcha question, and I'm so sorry, but I am desperate for the answer, and I think we kind of all need to be at this exact moment in time. As we're building the next healthcare ecosystem of information, how do we do radical thinking around equity so that everybody benefits equally from that information ecosystem? No pressure.
I do think that health and hospitals is innovative in this way. In other words, you have programming that sort of elevates your work above the quote-unquote equity discussion that is, our interim commissioner of health in the city is scrambling to get out there, and to change the way we use algorithms and all of that piece, that work. But I do think we can't wait. And what I love that you're doing, and I wish that there was a way for us to let our data show longitudinally the impact, is the wellness work that you're doing. I mean, but that involves consumers. That involves people being given tools to make the changes they can make and wish to make. So, you know, that's a whole part of this discussion that for the next, you know, event.
Next year.
We need to talk about. Thank you for that question.
I will also note, like we just did a project for the Arnold Ventures Foundation using data from 3 state APCs, including Massachusetts, where we paired hospital discharge data, where the race and ethnicity data was better, with APCD claims data to really look at systemic financial inequities in our healthcare system, which again shows the value of having these data resources sitting next to each other in an environment where they can be used. And I think that DOH and NICE are starting to kind of build environments that can host data to support such analytics. But yeah.
I do think that that's important, but I think to your question, really the answer there are the people that we treat like widgets, quite frankly, to just do what we design, et cetera. And I do feel like some of the democratization of data is letting our communities know how they can live long lives with quality and without imposing bias upon that. That could be true for everyone.
For sure, and that's why like the concerns about AI, right?
Yes.
Because AI is like telling us it can think for you. I don't want it to think like me. I want to change how I'm thinking right now. And so that's why I think we have to resolve many of the ethical questions around its use and application.
Hi, my name is Neelam Brar. I'm the CEO of Total Life. We're a national network of behavioral health providers entirely focused on healthier aging. We're mission driven. Our culture is around helping older adults access care that is covered by Medicare so that they don't have to worry about cost as a burden. One of the things that we've noticed is like there's a ton of data around the impact of behavioral health on overall health outcomes. Untreated depression leads to a 60% higher likelihood of dementia, 50% higher likelihood of ER visits. The mind-body connection is real. We don't need any more data telling us this. I loved your question about what are we doing with this data to ensure that the patients are getting access to the wellness. My question is, you know, we've built this platform. We have access to behavioral health practitioners. We see amazing outcomes. But how do we get the support from the data so that primary care doctors are prescribing therapy instead of antidepressants? Let's get people off the medicines that have so many other side effects.
Wow, you're asking a lot of. Yeah, I mean, it goes back to what Erin raised, which is to let the data speak to integration. I mean, I feel like I'm not sure all of our patients in the internal medicine field want us to start them down the path of, you know, complementary and alternative and, you know, other ways of even wellness. You know, we're still sort of learning that, and to have kind of validity when we're going to our patient population to sort of push that forward is tricky. I do think that integrating data streams in reporting is what's going to make that difference. So let's say primary care is the hub. The spokes from that hub matter. And I feel like that's what Erin and CHIA is suggesting, that maybe we can look at the whole pie a little bit differently rather than segmenting it. And I think that's part of what you're saying.
And you've added new segmentations for race, ethnicity data. And
It's coming.
okay.
We have time for one more question if there's anybody else who'd like to ask one. Well, if not, I just want to thank all three of you for sharing your time and your expertise with us today. It was a wonderful conversation, and we're so lucky to have you all be a part of our summit today. So thank you so much. And hold tight. We are just going to switch the mics before our closing conversation.
Senior economist on the President's Council on Economic Advisors, and of great importance to all of us in the room from New York. She is now the chair of the New York Commission on the Future of Healthcare. So I'm going to start out by asking you, you once said to me recently, everyone loves data, but why? So what did you mean by that?
Okay, so, do you like hardware stores? I love hardware stores. Like when I'm in a really bad mood, it cheers me up to go to like Home Depot. And they have fantastic tools. And sometimes you see these toolkits and they're really shiny and beautiful and everything is wonderful. And you could take one of those home and you still could not do any carpentry, right? Data is like that. So everybody loves the idea of data, but actually using data is really hard. And data don't just tell you what you want to do, nor do they answer questions naturally. So data have become easier and easier to produce or to have available because we have claims data and big data and all that stuff. But actually learning from data has not become any easier than it was, because that actually requires articulating a question and thinking about how to answer it. And I do worry that we put a lot of resources into building the data system and we don't think a lot about what we're going to do with it afterwards. So what are we going to do with the data? And that's not always straightforward.
So, we've talked a lot about health data, but as an economist, do you look at data differently than an epidemiologist does or a public health person?
Yes.
And so I want to know, what is it that you look at and why? How do you think about the health care from an economist's point of view that would be illuminated by the kind of data that we're talking about?
Ooh, that's a hard one. Okay, so the last part of that makes it really hard. So economists are strange animals. And they're particularly strange because they have a particular approach to data that is very much ingrained in the theoretical basis of economics, which started in 1776 with Adam Smith. All economists can remember that because it was 1776, which is that the difference between correlation and causation, which is like super key in economics and not a big deal in, for example, epidemiology. And it's just the heart of economics. So all of economic analysis of data is about the difference between correlation and causation, which means that descriptive data, which is what we mostly produce, is not all that useful.
Okay, but that's a pretty, so all of us, I don't know about you all, the public health and primary care people in the room have just gasped collectively.
Yeah, no.
So you're basically saying it's not useful, but keep going. Tell us more.
Because it's not enough to know. All right, I'm going to pick on Massachusetts, and I'm going to pick on my own friends because I'm on the Millbank board and we spend a lot of time talking about the share of money spent on primary care. And that's a nice number. But so what? Should it be higher? Should it be lower? How do I know? Because it's higher in Massachusetts than in New York, does that tell me anything? I would like to know, what does primary care do? How do I figure that out? That's a really hard question, actually.
Okay, so I was just going to ask you, we've spent a lot of time talking about, primary care gets 5 to 7 cents on the healthcare dollar, and we think that that's insufficient. Most other similarly situated countries spend somewhere in the 12 to 15 cents, and they spend much more in social services. So clearly we're not spending enough. What do you think that either tells you, or what do you think that leaves out?
So the question is, I don't know, I'm being really provocative because I had a bad day, so I apologize that this is just me being really provocative, and also, this is the end of the day and I want to keep you all awake, right? So the question of how much we spend relative to other countries is highly disputed. Let's just put that to the side for a moment, how you count what is social services, blah, blah, blah. I don't want to get into all that, right? But the right question is, if we took $500 from somewhere, and let's suppose you don't get to pick where we take it from, because unfortunately you don't get to pick where we take it from. It would be all fine. If I got to pick where we take it from, I'd say, take $500 from Elon Musk, give it to PCDC. That's easy, and I'm sure that would do everybody good. But suppose we don't know where we're taking it from. We're just taking it from a random place. How much more health do I produce by giving that $500 to you than I do by giving it to someone else? That's the right question, not how much are we spending, but how much more or less would we get by moving resources around? That's the causation question, not the correlation question.
Okay, how do you figure that out? That's a great question. So how do you figure that out?
So, all right, so economists spend a lot of time trying to think about how to figure this out. So you can do randomized trials. You could say, what happens in this neighborhood if we put more money in it? What happens when you guys build a clinic here and not there? Does the health of the people here improve compared to there? Those are questions we could ask of our data, right? And would be great to answer. And we actually have data, and we should be doing a lot more of it. But that requires more than just having the data. So I am struck by all right, so New York was a leader in data. We built Sparks in 1979. I've been using it since, I don't know, most of you were not, I'm not that old, since most of you were not born, right? But there's so much about inpatient hospital care in New York that we've never asked or know. Because if you don't, just having the data doesn't mean that the questions get answered or that the questions even get asked.
Right, I think that's right. I mean, one of the things that I said sort of in my introduction was we have a lot of data, but we only can measure what the data shows us, right? Or what
but we also have to ask the question of what is it we want to measure. So can I give you an example from the commission? All right, so we're talking about hospitals. As you know, hospitals are the thing that one of the two things, we're asking about two things, and we can't answer either of the questions right away, the first questions we asked. One question is, what do hospitals do? Turns out, it's not a hard question to answer. You can answer it. But there isn't an answer out there. What are people, if you walk into a hospital, who's in the beds? When you ask people, what do we need hospitals for? They tell you heart attacks and strokes and maternity care. But if you actually look at what people are in the hospital, what is actually happening in the hospital, who are the beds filled with? Those aren't the people. Lots of beds are filled with people with psychosis. Is that why we need hospitals? But you have to use the data. You have to ask a question of the data that the data doesn't tell that to you. You have to ask it.
Right, but that's saying what do hospitals do and what should they be doing?
What should they be doing?
Those are two separate questions.
Well, even what do they do is not a question that just dumps out of the data for you. You have to ask it.
So do you think that data tells us today what primary care does?
No. So we have to ask the question, what does primary care do? And we have to really be rigorous about it. So we haven't started working on this. This is next year. Be prepared. But why are people going to primary care doctors? What are the things that primary care is doing for them? It actually turns out we've been doing a little bit of, this is like separate from the commission, just noodling, because you asked me this question one day, so I started to look at it. So we've been looking at the National Ambulatory Medical Care Survey. So it turns out what primary care doctors do today is quite different from what they did 20 years ago. People come to the doctor for different reasons than they used to. Part of that is a bunch of drugs have gone over the counter. People don't have to go to the primary care doctor to get them anymore. And so we have a different mix of stuff. We could do this with the data, but you have to ask.
And do you think we could do that with existing New York State data? Can you tell us a little bit about what you think about
I'm sorry,
like
now I
the
went
state
off
of
like
New York
totally.
State data?
Well, yes, that was supposed to be. All right, so what do I think about the state of New York State data? We have a lot of data. It is extremely poorly connected. So the state itself does not connect its own data. The programs within the state do not connect their own data. We asked a question, so as many of you know, New York City and New York State has vastly expanded access to personal care. We have this new CDPAP program. So being a naive person, I asked a question like, do people who get CDPAP go to the hospital less? Well, it's not even possible to answer that question because those two data systems are completely separated. That would seem like a question the state ought to be asking. So we have a lot of data, and even within the health system, even within the health department, it's not connected. Across the health system, it's not connected. And then think about the questions you could ask and answer, to your point, if you connected that data to even more. Like state unemployment records. How many people, what's happening to workers? Are they actually using services or not? And when we put primary care in a community, do people wind up working more? Does it improve hours of work? That'd be really cool. That would help you. That would be a good sign for the goodness of primary care. Could we look at the state workforce data and see when we train people in universities, does it affect whether the hospital is staffed well or not? And what does that do? So there's lots of policy that we could study even within the state it's not just connecting the data. If they connected the data and somebody said this, and asked the questions and then was willing to live with the answers.
Right, so many things. I mean, I think sort of the way that I think folks thought maybe this was going to happen when health information exchange was first starting, I don't know what we're talking about now, 20 some odd years ago, was that every person, every individual would have a number, and every provider would have a number, and then you'd just be able to like sort that out together. Do you think is that an answer to the connection problem?
Well, then you would have highly connected data, but you still wouldn't have anybody asking questions. So you still have to ask the questions.
Okay, you still have to ask the questions, but I think the question about why is it that we can't connect data, some of it is what I think was mentioned earlier about concerns about data, about privacy,
within the
right?
state. There's not there's not a privacy problem in the state in principle in connecting the state's Department of Labor and the state's Department of Health.
Yeah, you have to have a universal identifier of the,
No, we could do that. We have social security numbers. You could do it. That's not a problem. It's not a technical problem. It's not a technical problem. It's a will problem. Part of the reason it's a will problem is because nobody really knows what you would do if you did that. So if you did it, it'd be great, and I'd love it because I love doing that kind of thing. But what would people do with it?
What would people do with it? Or do you think that the question is there might be to Susan's point, there might be an answer that you might not
Or
like.
people might not like the answers, and then they wouldn't want to do anything with it, right? But I worry about if you build it, they will come. I actually think you want to be thinking about what are the questions that you'd like to ask, and how are you going to assemble the data to answer the questions you'd like to ask. I tell people, so when I was at ASPE, somebody had this great,
you should say what that is.
well, in HHS, in the federal government, there was a big, many million dollar allocation to build an all-payer data set that would combine data from commercial claims, Medicare, Medicaid, everything for like some samples so people could do research, and all these people were very excited about it, and we finally got Optum to build it. And they linked Optum data and Medicare data and Medicaid data, and then we were like, would anyone like to use this? And we got 0 takers. Nobody could really figure out what they were going to do with this great data set that had everything linked.
Well, that's so interesting to me because I feel like there's been a lot of conversation here today, and I think people are talking about, like, I would like to know the answer to this question, whatever it happens to be. Do you think that is it that researchers are asking questions that don't really relate to what policymakers are thinking about? Do you think policymakers are just asking questions that really aren't answerable by the data? There's a disconnect
Yeah, so I
here
think
that's
part of
broader
it is,
than-
so I think, honestly, I'm just being really sorry.
It's
That
okay.
there's a lot of good things you can get out of data. I love data, and I spend all my time
I don't know, I'm
swimming
going
in
to go
data.
with you to Home Depot soon, so I'm just saying
I love,
that's actually what's
I
happening.
love data. So, first of all, policymakers are not usually people who think about data. They don't really understand data at all, and that's fine. That's just not what they do. They might not want to know. They might want to know something like, how many people work in my district, or something like that. But they're not. Most of them are lawyers. It's okay, but they don't really understand. My husband's a lawyer, but they don't really think about data in terms of. They might think of data as evidence for an argument that they're making, but they were already making the argument, right? They're just buttressing it with your data. They're not really looking for an answer to a question in that way, in the data way. And researchers are off here doing whatever they think is really fun. So I think there's a lot to be, okay, so now I'm sounding so depressing and so pessimistic, but I don't mean that. I actually think there are good answers to things that we can come up with. I think there are good things we can do. We can learn. Things can be better. There are good examples of it, even. I just worry that if we only focus on building the data and we don't really start from the very beginning in really thinking about what are the questions, how do we think about this, how do we tackle this correlation and causation problem, right? That it's not just a number, it's actually what does that number do, what happens if we move it. You can think about building data in that way and answering questions in that way, but it doesn't just happen because you went to Home Depot and bought the tools.
Yeah,
There, look at that.
I think, well done, kind of circle back around there. I guess I'm interested in the question that got raised about timely and, data on the spot, timely data, and sort of the more longitudinal data. And one of the things that was really clear to me in the pandemic is we knew almost nothing, right? In spite of the fact that we have health information exchange around the country, we actually couldn't figure out were people actually accessing care? What kind of care were they accessing? And we weren't able to turn that into actionable activities. And then a good example was that we couldn't figure out, so at a certain point, hospitals were overrun, right? And yet the primary care system was underrun, if you will, it was underutilized. And we weren't able to turn that tide, right, until certainly then, once vaccines came in, then everyone was, then everyone said, oh, it's the primary care system's problem and they have to fix that. But it seemed to me, and we sort of tried to do this with one of the local health information exchange and just couldn't get there, which was, can we say something about what's happening with primary care in order to help drive a policy that would say people should go to their primary care providers, of course, or call or get telemedicine or all these things, and not go to the emergency room under these circumstances. And you could have created a whole public health sort of campaign that would have really changed, I think, how people were trying to access care. But instead, we focused on the fact that, we sort of told people, go to the hospital, go to the emergency room. And I think my friend over there, Helen Arteaga from Elmhurst, which was the epicenter of the epicenter, would certainly say that the primary care system could have decanted that. But we weren't able to get the data, and it was hard to figure. So what do you think about the real-time data?
That's a very good question. So I should be really careful. There's data for making policy decisions. That's a long-term thing. It's not a immediate thing, except in COVID, but COVID is kind of weird. So let's think about, let me parcel that out. But there's also real-time data that you need to manage the system. That's a different question. Management is different from policy in this sense. I track how many students we've admitted each month to Wagner. That's a different thing than a policy analysis. If I'm trying to decide whether we should change our marketing strategy, I can't just look at that dashboard, right? I have to think about, well, if I added $1,000 here, what would happen, right? But just to know I need to know what's going on all of the time. And sometimes when you're thinking about capacity, for example, that can be tremendously important. So yes, we need real-time data. New York City had this real-time epi data, right? That was looking at how many influenza-like illnesses there were showing up at the emergency rooms. That is very powerful data. It's very useful. I was like watching it every minute all the way through the pandemic. So I don't mean to, but most of the data systems that we're talking about are not going to provide that kind of data. And so that's a kind of data for management purposes that you might want to be thinking about providing. Now, let me say, if I were Kaiser Permanente, I'm guessing that they have those data. They're trying to figure out, and I wonder whether they were able to send people to clinics instead of to the hospitals because they had the data. Because they were integrated, and so they were managing the whole system. We don't manage our healthcare system in that way. We lay out policies, right, that encourage people to do things, but we don't. New York State doesn't track where people are. I wonder also, did the NHS do that? Were they better able to do it because presumably they are tracking how many visits did every clinic have in each day. So I think the issue of dashboards and real-time data can be really important in terms of managing the system once you know what your goals are and your policies are.
Yeah, I think your distinction is well taken, right? And I obviously am overstating it to a certain extent. There were a lot of reasons why primary care closed down and all kinds of stuff like that. And I also think that there is but I would say that there's, in this country in particular, I think people see hospitals as the place they should go. And this was true many years ago when we had the other flu epidemic, the flu epidemic, right, a number of years ago, where we did sort of a small study in hospitals and in the emergency rooms, because we were saying, you could go to your primary care provider, but people were showing up at the hospitals, and the hospitals were completely overrun. And the common thought at that point in public health was that, just people didn't have access. But when we went and asked them, what they said was, I thought this is where I was supposed to go. Right. So there's this thing about management, there's this thing about messaging, and then there's this thing about policy, those things together.
So it's also really interesting, right? So we've just come out of Medicaid redetermination, the end of the unwinding. So we did some work on the unwinding in Medicaid. And one of the things that was really curious, and it turned out actually it was true, is that there was an enormous increase in Medicaid enrollment in the CMS data and every state's data. That increase in enrollment did not really happen in the survey data. And so in the unwinding, there was an increase in Medicaid enrollment in the survey data, but it was far smaller than the increase in enrollment data in the state and national data, in the administrative data. The reason is that the way the state works is when the Medicaid continuous coverage happened, the state said everybody who was on Medicaid in March of 2020 is on Medicaid. They're on Medicaid forever. When you ask people, are you on Medicaid, some of them had gone off and gotten a job in the meantime. They were on employer-sponsored health insurance. Or they thought they were uninsured. But the state still had them on Medicaid because we didn't tick them off, right? So some of this is what's actually happening, and some of it is what do people think is happening? What do people think? Where do the people think they should go, as opposed to where do they have capacity, as opposed to where do you think they have capacity? And somebody had spoken about that. I think you spoke about that, right? The survey questions, both of them provide information. It's not the same information, and understanding the disconnect is really important.
So I wanted to go back to something you said earlier, which is if we wanted to really figure out what the right thing to spend our money is on, we would do these sort of trials where we would say, well, we're going to give this organization or this community more money, and we're going to give this community not more money, and then we're going to see what happens. I mean, those are things that are not so realistic, right, in the world as we say today, because and trying to figure out how do you make those determinations, and then the assumptions about how do you then go to scale with what you learn out of that, right?
So lots of trouble with experiments, right? And I don't think you could do randomized. Let me be very clear here. I don't think you could do randomized controlled trials of primary care. I think that'd be a hard thing to do. I think there are actually, I mean, I'm not going to talk about economics, but there is an armamentarium of methods that are short of randomized trials that you could do. Right? You could look at the fact that you only fund a couple every year, and you could figure out how you do that, right? What's the difference between the one that you funded that only started the year later, right? You could do staggered, right? There's lots of things you could do. We could be evaluating things much more continuously if we wanted to. You don't have to do randomized trials to evaluate things.
This is the Home Depot of economic tools, is what you're basically
exactly.
saying.
You know,
Okay.
you might not have the most expensive tools, but you could have like decent tools if you know how to use them. But I don't mean to push you particularly, because I think this is an organization that has been pretty forward about thinking about evaluation and thinking about what you're doing. But we do have, but we should be very careful about the distinction between counting things and thinking about what to do next. Those two things are different. Counting things is very important, and figuring out what to do next is not the same thing.
So I want to go back to this issue of do we spend enough money on primary care or not, and how we would figure that out. So, you know, the data seems to us pretty clear that primary care helps people become healthier. It helps them be able to go to work and to school. It helps it in all sorts of ways. But we know that it is actually one of the least funded, other than behavioral health and public health, which are below primary care, right, just saying. It's funded at a much lower level for all kinds of reasons.
Yes.
For example, the AMA has this relative
Value,
this whole thing where they basically decide that, that the skills and 15 minutes of a dermatologist is worth X amount of money, and a primary care is worth much less, or half of it. So but we have to be able to make some assumptions, right, and say we have to build our system in some way going forward to say, we think that one of the things that would help a lot would be to actually rebalance the system so that whether it's 12 or 15 cents, I don't know that I'm going to argue that on the healthcare dollar, but I don't think it's 5 cents. So how do you figure out how to take those assumptions and get them to go to scale at a policy level while we're figuring out all these other really good questions?
No, I don't mean to suggest that we don't need to spend more money on primary care.
Okay, well, you heard it here, folks.
You're all my friends. It's all good. And the fact that we pay enormous amounts for specialty care in lots of crazy ways probably doesn't do anybody any good. So if I got to do my Elon Musk routine, and if I were the czar of all the Russias, and I could just move money from some of those orthopedic surgeons to you, I have no question that probably would enhance people's well-being, right?
But that's a false answer. It's not moving money from the orthopedic surgeon. What it's moving money from is all the the ambulatory care-sensitive hospitalizations and emergency room visits that happen because people don't either have access or they don't go.
So that's a causal
not taking
claim.
money-
So that's
okay.
a causal claim, which hasn't been very well studied for the last 20 years, right? I don't know the answer to it.
How would you answer that question? How would we go about saying, like, if we wanted to?
I think it's a great question. I think it would be really great to bring a bunch of people together and say, how would you answer that question? I don't think I'm going to, I mean, I'm not a brilliant economist. I'm not going to tell you the answer. I don't know the answer right now. But there are some people who think about this, and we could ask the question.
All right, I think that's a really important
I
question.
also think there's another flip side of it, which is also really hard. This is a question we asked at ASPE. Suppose I paid primary care doctors 50% more than I do. How many more primary care doctors would I have and when? We actually don't know the answer to that question either.
Right.
We find that, so it turns out loan forgiveness does not help, right?
Yes.
Free medical school does not help.
Right,
What
because
we
it's
actually
in a context.
What we actually do to increase the primary care labor supply, we don't really know. So a question about my giving you extra money, right? Let's just imagine. This is me speaking as an economist, not as a commission, right? Not the commission. We haven't even looked at primary care. But I think a question is, well, what would you actually do here? What is the step you would take that would actually increase the number of people, the number of primary care doctors?
Right, but and I think this is really an important conversation because that is one of the questions about what you would fund, but it's not the only question, and I think sometimes.
No, right. But
So
I'm just saying
one
that's
question.
a
How do we
question.
get more, not only
That's
more
a
primary
question.
care providers, how do we get more nurses who are in primary care? And the question is, so this is a contextual question, so just talk about nurses for a minute. You know, if nurses, I have a good friend who got trained as a nurse, he wanted to work in ambulatory care, 100% of his nursing training was in the hospital, 100%. There's no context in which he was even introduced to primary care.
Lots of
So we need
things
to
that we
figure
could,
out all the
lots of
building
things that we
blocks.
could do, right? I'll ask you one. I'll put one to you that I think is really, really challenging and interesting. A great researcher on primary care and other things at the University of Minnesota, a woman named Hannah Naprash. She just finished a paper, and I don't know if it's published yet, so shouldn't tell you what it is. But it asks the question: in a clinic that is staffed by primary care doctors and nurse practitioners, how do patients get allocated between the primary care doctors and the nurse practitioners? And it turns out just random.
All right, well,
Across the
that's
system.
one way to think about it, but I also think that there are ways to really think about team-based care in a very, very different way.
No, absolutely.
And so we have to transform, to points earlier, the way primary care delivers care.
Totally.
We have to figure
There's a
out,
really
I
interesting-
think.
that would be a really
right,
interesting one.
The way we
Okay.
have to finance it, and then I think we have to figure out
I'm sorry,
all
I
the regulatory supports for it. But having said that, I mean, I think we're arguing within the family, I guess I would say, about thinking about this issue. But you raise a lot of good questions. So I guess I would ask you this as a final question. So what do you think the most useful next steps would be? Perhaps it's the 1 in 5 year question that we asked our panelists,
Right.
but what do you think the most useful next steps would be to sort of try to, New York State to wrestle with this question about primary care, access, spending, quality, cost?
So I would love it if everyone in this room would think of a question. It's not like how much are we spending on primary care, but like if we did, the question should be, if we did X, what would happen?
Okay.
And let's see how many of those I can answer, right? We can actually answer quite a lot of questions like that. We have enough data to answer a lot of questions like that, but nobody has any particular incentive to do it, so.
Okay, so the charge that I think
You
you're
can send
giving
it to
us
me.
is you can send it to Sherry, or you can send it to me, lcohenpcdc.org.
Around primary care, what are the questions
What
we
is
should
the
ask?
question that we should ask?
About, that has the form of, if we did X, what would happen? Not how much of this or how much of that, but, right, if we did X, what would happen?
Okay, so, and then next year you'll come back and we will.
We'll try to find, and
Answer
send
those
them to me,
questions.
and I will arrange a conference, and I'll get a bunch of people together to talk about how you can answer those questions.
All right,
How's
that is
that?
fantastic.
That's a deal.
That is a great deal. We're going for that. I want to thank you. I want to
right.
thank our panelists. I want to thank the staff in particular for doing a great job pulling this together. We have a lot of food and drink. I urge you to imbibe and consume before you leave here today. Thank you very much for coming.
That was fantastic. They were lively. People didn't.
My main goal is that people shouldn't fall asleep while I'm talking. I hate it.
Yeah, I know.